You're watching City Channel 4, your window to our community.
Today, I want to welcome and thank one of the leaders of Honoring Your Wishes, a community advanced care planning initiative. This has been a wonderful community initiative that we have partnered with every healthcare entity in our community to change how people interact with the medical community when an issue arises. Heide will say more, but Heide will be presenting today. Heide Bursch, Nicole Peterson are our presenters, and I now turn this over to Heide, who's going to talk about Honoring Your Wishes.
I'm Heide Bursch, and I am a nurse researcher with an interest to improve the care for older adults and their families. And as such, I have been involved in the Honoring Your Wishes community initiative from the very start. What is advanced care planning? It is a process. It's not a product, it's a process, and I'm going to be saying that over and over again. For you to discuss goals for future healthcare decisions in the context of your values and beliefs. It's a process in which you can create or update a written plan, an advance directive that you may already have, and you can state your preferences for how you wish to be cared for, and also, very importantly, it prepares others to make healthcare decisions consistent with these preferences. So I will be talking about healthcare agents, which are the same as proxies or surrogate decision makers or durable power of attorneys for health, somebody you would appoint to make decisions for you in the event that you cannot make your own decisions. I want to say that advanced care planning is very different from the advance directives that we have traditionally completed. Usually we complete the traditional ones in the hospital or at a lawyer's office or in a long-term care facility. And the most important difference between those advance directives and the process of advanced care planning is that the process includes the preferences at the end of life into the decisions we make about our healthcare decisions all lifelong. So advanced care planning really starts at birth. And in our current medical system, we have to make decisions about our health care at any point throughout our lives. So advanced care planning is just a very logical conclusion to take us from birth to death, and it allows us a certain measure of individualization and control over how we want to end our life, just like our mother had control over how we began our life. It's not a simple decision like an advance directive where you just decide whether you want to be DNR or a full code. It's more about all the decisions that lead up to that last final spot when it's like, well, do you want to be coded or not? Advanced care planning takes time. It takes time to understand why you have to do it and who you are and what your special circumstances are or what the circumstances of your illness context are. And you need to reflect over your values and beliefs and how all of this comes together in your preferences. And then, most importantly, at the end, you have to have a conversation with your healthcare agents and your healthcare providers. So you learn about your future medical options, you think about your values and beliefs, and then you share your preferences. And again, while we all know that we're all going to die eventually, death seems to be shrouded in mystery and uncertainty. And we don't traditionally talk about dying until there's certainty of dying. And by then, 50% of us will not be able to participate in the decision making. Most of us will die after a period of chronic, progressive, and ultimately fatal illness. And we will be cared for by healthcare providers in institutions or organizations such as a hospital or a long-term care setting or some other type of facility. So healthcare providers will oversee our care. And if they don't know our preferences, if we have not communicated with our healthcare agents, if there's uncertainty, we will always receive the default care, which is everything, in the context of there's nothing else to be done. These conversations are obviously difficult. What does healthcare planning include? It includes 2 tasks. The first one is to choose the healthcare agent, the person who will make medical decisions for you if you're unable to communicate. The second one allows you to reflect over a hypothetical situation. If you had a serious neurologic injury, for example, a stroke or a car accident, or for younger people, 18 years and older, it could be an athletic injury or even an assault, different scenarios. We all may have a sudden, surprising, accidental event. So, thinking of this surprise event that happens to perfectly healthy people, that would be the first step for most of us. When we're healthy adults, we start doing advanced care planning, and we simply try to anticipate what we would want done in case of such a devastating neurologic injury that happens out of the blue. We are looking for 4 particular characteristics in our healthcare agents. And the first one would be that it should be someone with whom you can openly share your values and goals. You have to have a trusting relationship, and you have to be able to talk to them. So long-distance caregiving, it's difficult. You may have to do it over the phone or with Skype or something. But it's important that you're comfortable with that person, obviously. That person that we're trying to involve in our healthcare decisions needs to be willing to assume that role. And that doesn't come easily to some people. For example, children having to make decisions for their parents, or a spouse having to make a decision for her significant other. That is something that some people would prefer to leave up to, for example, the doctor or the children. And that all needs to be discussed and addressed. And they need to be willing to follow your wishes. Sometimes healthcare agents and patients have different opinions about what should be done at the end of life or in the event of this neurologic devastating injury. And the healthcare agent you choose must be willing to follow your wishes, even though perhaps they don't agree with them. And if you find that that is too hard for them, you might look for somebody else. Finally, they have to be able to make decisions in stressful situations. Because I think, as we're all familiar with, when somebody's health condition deteriorates rapidly in the hospital or there's a sudden event, it's very stressful. And people have to have their act together, and they have to be able to advocate for you, your healthcare agent. And they do that best if you've actually talked to them, obviously. So they need to be empowered. Here is the what-if situation. This kind of sets the scenario for how we want to think about our first steps advanced care planning. The sudden serious car accident, perhaps you have a brain injury or a spinal cord injury or something, and the doctors state that it's unlikely you will recover the ability to know who you are or who you're with. And you notice the word unlikely. There is no certainty about any of this. It's just highly unlikely. What would you decide? Would you want to continue life-prolonging treatment? Would you want to stop life-prolonging treatment? And this really gets at the core of a person's healthcare beliefs and perhaps their cultural and spiritual or religious beliefs about life. To some, life is sacred at all cost and under any circumstance. And if you have this neurologic devastating injury and you're about to be transferred to a long-term care facility, you will have the feeding tube and you will have the ventilator if needed. And that needs to be clearly spelled out. On the other hand, if you're the kind of person who says, that type of life has no meaning to me and I'm not in it anymore, and I would not like to have the tracheostomy and I don't want to have the feeding tube, and I would be fine to receive comfort care instead, then that also needs to be discussed. And that is perhaps difficult for, say, example, the social work students, or it's an interdisciplinary student body that takes the end-of-life course with Sarah Sanders at the University School of Social Work. They all have the assignment to make an advance directive, talk through with a facilitator, and take that directive home to their family and talk about it over Thanksgiving. Mm-hmm. Yes. So that would be difficult to tell your parents that, you know, if I can't run and jump and dance and sing and whatnot, I'm fine just dying. And again, here, a 18-year-old will decide differently than a 35-year-old with 3 children, or a 65-year-old who has grown accustomed to, you know, a slower pace of life and can put up with a lot of losses, or than a 95-year-old who just is plain tired. So think about what living well means to you. And living well has been questions have been developed to examine this reflection by Respecting Choices at Gunderson Hospital in La Crosse, and we're using their model for our Honoring Your Wishes model. So the living well questions are: what gives your life meaning? What activities or exercises do you want to be able to do in order to say that you live well? What cultural or religious beliefs are important to you that should be included and part of your living well? What fears or worries do you have about your illness or medical care? That would speak to those persons who have a chronic illness and are going to anticipate specific medical choices. So you reflect about what it means to you to live well. Then you have those discussions and you share your thoughts with your circle of support. I think that's a very nice term for whatever family, traditional or non-traditional, we have. And then you need to talk to your healthcare providers about this as well. Now, what would the next steps be? Some of us may be ready to put this in writing, put this in a document which was developed by the Honoring Your Wishes initiative. And this document is accepted by all healthcare facilities in Johnson County at this point. It's a 12-page document. The first 2 pages are simply instructions. And they're written in ways that everybody can understand them. It's not that legalese that you find in the State Bar Association forms. So I say some of you may be ready to put that on paper, others may not. And what we're emphasizing with our advanced care planning is that it's really the conversation that is the most important part. Because doctors don't necessarily need to have everything in black and white on paper unless there's conflict. They need to know from the healthcare agent at the point when it's necessary that they've had that conversation. And they need to see that the healthcare agent can advocate with conviction. So the conversation is very important. So we have the Honoring Your Wishes document, which is a directive, and we can all fill that out. And that is different from the I-Post form, which Nicole will speak about next, which is actually a medical order. Okay, so the directive just captures your wishes regarding life-sustaining treatments and what makes life meaningful to you. There are nice little sections in the document where you can write about or leave messages for your healthcare agent just to encourage them and thank them. directive is good for persons who are in the first steps and next steps stage of advanced care planning. And when I say first steps, that is healthy adults who have no way of knowing. There's a great deal of uncertainty about their death, and they just prepare for that devastating neurologic injury. The next steps is for persons who have a chronic, progressive, life-limiting illness or two. Usually these chronic illnesses come in pairs, don't they? So they have a much better idea of what medical choices they may have to anticipate. And one can become much more specific about how they feel, say, about CPR or about a ventilator or about tube feedings, all these interventions that we can do when somebody needs support, but that we can also choose not to have. And then the last steps is what Nicole will address, and that is the I-post, which is designed for persons who are clearly at the end of life, where the physician says, I wouldn't be surprised if this person was to die within the next year. And those are usually people who are in nursing homes or at home with end-stage disease or in hospice care. You need to share your plan, like we have said. In Johnson County now, the hospitals all accept the Honoring Your Wishes form. They scan it into your medical record. And the Joint Emergency Call Center, I think, the JEC, Communication Center, thank you very much. They have agreed to keep a record of persons who have completed an I-post form, so the last steps. And that's a good thing to know, because then when they're called to that address with a 911 call, they will know to ask for the I-post form. When it says others here, we have found that people like to share their advance directives perhaps with their spiritual advisor or the leader in their religious community, and they even keep a copy of their advance directive at the church or mosque or wherever they worship. So that's nice. We have quite a few faith communities involved in Honoring Your Wishes now. These conversations are not easy. And once you have had a session or an interview or a conversation with a trained, certified advanced care planning facilitator from Honoring Your Wishes, you will have the vocabulary and the ability to articulate your wishes and your fears and your preferences and values and beliefs to your family. You will be able to empower your healthcare agent to embrace that role, and the healthcare agent will have spoken with the facilitator as well, will be involved in the communication conversation. That's so important. So having a session with the certified trained facilitator is helpful for many things, least of all empowering your healthcare agent. When you go home and say the students doing this at the Thanksgiving dinner table with their families, they will open the door for the families to follow their example. The parents might start thinking about completing something like that for themselves, their siblings, aunts, uncles, whatever. And you will set an example. The students will set an example about including death in the continuum of life and facing death with a plan, with dignity, and the measure of control that they wish to have, which for some is, complete control, and for others it's like, you all decide. But that needs to be talked about. Of course, like we said, it's a process, and the document is a living document. We need to revisit it periodically. Some churches are assigning one Sunday every year to remind everyone to update their advance directives. So, because your wishes might change due to your health status, or your goals, values, or beliefs have changed, or you decide to select a new healthcare agent. Perhaps you got divorced, or perhaps your spouse is developing dementia, Or perhaps you yourself are developing dementia and you want to become much more specific in your plan. In summary, planning ahead is a gift to you, and it's a gift to your healthcare agent because you open up the door for this conversation that is very meaningful, and you empower your healthcare agent to speak for you. And people have experienced it as a relief, as emotionally helpful. For example, a father had difficult time telling his cognitively impaired son that the father, he was dying from a terminal illness. And by talking with the facilitator, he got the words to be able to have that conversation. Or a mother was able to decide that she wanted to have more household help at home so she could spend the remaining time playing with her toddler on the floor. Or a patient decided that really he didn't want to have to go to the hospital every week, long travel, to have blood work done when he could just stay home and spend time with his family. On the other hand, there was a mother who was able to receive more aggressive therapy with a limited short-term goal that she wanted to accomplish before she died. And it is a gift when you can lay all the cards on the table. I think we have time at the end for questions. So now I would like to hand it over to Nicole Peterson, my colleague.
Hello, I'm Nicole Peterson. I'm a geriatric nurse practitioner. I'm also on faculty at the College of Nursing. I am a clinician and also just recently completed my doctorate of nursing practice. And I'm going to share at the end a little bit of my research that I did. And like Heide said, I'm going to go forward a little bit on the slides here. That's the website for the Honoring Your Wishes. And then in discussion of the IPOST, which stands for the Iowa Physician Orders for Scope of Treatment, like Heide said, this is based off the Respecting Choices curriculum, which is an evidence-based practice model created in La Crosse. And they were one of the POST movement stands for the Physician's Orders for Life-Sustaining Treatment, really began in Oregon in the 1990s. The La Crosse area Gunderson Lutheran system was pretty much right in there, right behind them, the leaders in this movement as well. And they created this curriculum. And the first steps, they kind of created their model with the first steps, second steps, and third steps. And the third steps is what the POST is based off of. And I'm going to actually show a video to kind of introduce this topic.
My husband, Max, was really a wonderful man. He was funny, he was delightful, he was charming, and he was a real rascal. He was a wonderful father already to his son and to his stepchildren. And we just brought the families together and created a new family. Max was diagnosed with aortic stenosis in about 1999. He went through a series of tests, and it became very apparent that the only way that this problem could be fixed, the valve could be fixed, would be to be replaced, would be open heart surgery. Max thought about it and thought about it for a long time, and then he became very clear with me and with his son Robert sitting there, I do not want this surgery. He filled out the advance directive and signed it, and I knew, and so did Robert, that he was very clear about what he wanted. He was born in Vernonia. He was a man of nature. He just wanted things to be natural and to go the way that he determined that they should go instead of tubes and you know, even though he loved technology, especially biotechs, you know, in his work, he knew what he wanted for himself. I had had experience with do not resuscitate orders. I had signed a couple of them when he was admitted after he had had syncopes and fainted and hurt himself. So I definitely knew what he wanted. And it was Mother's Day, and there were a lot of golfers in our family, so he went golfing. He went out to hit his second shot on the first fairway, and he collapsed. I wasn't there, but I was called immediately and was driven over. The EMTs blocked my view of him as I approached, and they asked me if I was his wife, and I said, yes, I am. And they said, we have not been able to get any vital signs for 15 minutes. And at that point, I said, please stop, stop, please stop. My husband did not want this. He would not have liked this. Please stop. I have an advance directive in my purse with me. Please stop. Then announced to me that they were going to take him to the hospital and that we should all go to the hospital. I touched him. I looked at him, and I knew he was gone. But I knew that as they continued to work on him, that he would not have wanted it at all. He would have hated it.
Emergency medical personnel have no choice. For people who are as sick as Max and who have strong feelings about what they want and don't want, advance directives are not enough. They need to be turned into action with medical orders, orders that say, do not resuscitate and no intensive care. If emergency medical personnel had those signed medical orders, they would have respected Max's wishes, and he could have died naturally, holding his wife's hand.
So this kind of introduces the gap that's existed in the current or in the previous healthcare system with advance directives. Previously, a living will, was a legal document, not accessible at the time that you needed to have it. With the POST forms now, it addresses way more than just resuscitation status and includes what level of medical interventions you would want, as well as the artificial nutrition, and identifies who your surrogate decision makers are for you. Puts it all in a nice bundled package. And so how we came with the iPost in Iowa, we actually changed, in the state of Iowa, we changed the POST form just a little bit. And in doing so, the National Post asked that you change the title. So that's how we have iPost rather than the POST form. But really minimal change. And then we in Iowa actually are the first state who have legislative backing for our state document, the iPost, which is really neat. I hope some of the other states start to follow that. Whoops. And we actually did not me, but there was a pilot project that took place over 3 years, started in Lynn County, disciplinary collaborative project between different hospices, different hospitals, community providers, and piloted the iPost in several care settings. And then the Iowa State iPost Advisory Council actually said, well, we need to try this in a rural area as well, so we know what that looks like in a rural area. And so this expanded the pilot project into Jones County, and found really good outcomes, really good feedback from patients and families as well as caregivers, that this was really helpful to be able to have this, and really kind of filled that gap where we didn't have before. And so the iPost was legislatively approved to begin statewide on July 1st, 2012. The Iowa Department of Public Health, as well as the Iowa Healthcare Collaborative, are two big places that have websites with a lot of training information, a lot of research information, resources for providers and resources for families, as well as the documents themselves. A few training things are all available for anybody in the state to use. The forms itself are available to order from the Iowa Department of Public Health webpage. And this is available to use. The iPost is available for any patient who is frail and elderly, or they have a chronic illness or maybe multiple chronic illnesses with complications, and people with a terminal illness, usually who have exhausted some of their treatment options and are really towards the end of life. There is no age restriction on the iPost in Iowa, which is really the first time that the pediatric population has been able to have a voice for their preferences for end of life. For people with, congenital illnesses or terminal illnesses who have exhausted their treatment options, they really didn't have a choice to say, I don't want any more treatment, make me a DNR. They didn't have that before. So this is the first time that we can do that for pediatric patients, and it's a mobile document that can go between care settings. So the iPost form is printed on a salmon-colored cardstock. It's a front and back paper, and it belongs to the patient and moves with the patient wherever they move. If they're at home, it stays at home with them. If they go to assisted living, it's in assisted living. If it goes to nursing home, it goes with them. If they at any time go to a hospital, they take the form with them to the hospital, so it's available to all the providers there, including emergency department staff and EMS staff, providers in the hospital. And then when they would leave the hospital, then it comes back with the patient. If they are to go to, this was something new to me in the pediatric population, there are a lot of people who who live in rural areas in Iowa and travel to Iowa City to get their care, and they go back home, and this is really nice for them to have that communicated preferences in their home communities as well. This can be changed at any time. The other thing I want to actually point out is if people move from other states, the state of Iowa has said that they will honor any post document from another state coming. So if they live in California and have a post there and they move to Iowa, Iowa will recognize their document as well, which is nice, especially for some people who travel snowbird, like Arizona, California. Those places will honor the post documents there as well. This can be changed at any time. Like Heide discussed, you may have a healthcare change. You may change your mind, you may change your values or beliefs, and it can be updated pretty easily. It can be done with any your healthcare provider or a Respecting Choices facilitator, and can be updated that way. The iPost form itself is signed by a physician and physician's assistant or a nurse practitioner, including a DO. So let me go over what the actual form looks like itself. And this is only part of it. It's kind of broken into 2 slides because it's a lot of information. But in the first section here, section A, that is addresses resuscitation status. And it says right here on the form that this is for a person who has no pulse and is not breathing. Then this tells you if they want you to start CPR or do not attempt any resuscitation efforts. So before, this is all that we had, was just the DNR. So really, this is a huge expansion on what the patient's wishes are. Section B goes into the medical interventions, and it tells you right on there that this is for a person who has a pulse and or is breathing. So they're in some type of a medical crisis, and we need to know how to treat them. So there's a continuum of care that the patients can choose. On one end, you have comfort measures only, which is keep me where I am. I don't want to transfer anyplace else. I want to be comfortable, whether that be medications, oxygen, suctioning, but just keep me comfortable and leave me where I am. On the other end of that, then you have full interventions, which include send me to the hospital. I want intensive care. I want anything that will keep me alive. IV medications, a tube in my throat, intubate me, keep me on the machines, maybe include dialysis, any of those types of things. And then in the middle, you have limited additional interventions, which is kind of in the middle where you want treatment. You don't want it to be very aggressive, but you want more than comfort care. So maybe that means going to the hospital, getting medications, maybe medications in your IV, definitely pain medicines, oxygen, maybe even a mask to help you breathe, but nothing that would be really invasive. So they can choose that there. And then there's another line on the bottom for additional orders. And this is for anybody who can really, they have a specific preference that's not addressed here in either of these three interventions. They can say specifically what they want. Maybe they have a really strong feeling about dialysis, and they can write it in here whether I would want dialysis or not want dialysis, or any other specific thing. Maybe they've had a treatment before that they don't want again. They can really make this patient-centered. Then on the this is the bottom half of the first page, then addresses the artificial nutrition, and also as well as just saying if I do want artificial nutrition or I don't want nutrition, you can say what type you want and how long you want it for, because there are a lot of choices. Maybe you want a short-term tube in your nose or down in your mouth, but you don't want one to be implanted in your stomach, or maybe you just would try it for a few weeks and then not have it. You can really say on here very specifically what you want. Then on the bottom we have the Iowa code for surrogate decision makers, and so we really want to try to get the higher up on the list, patient and their power of attorney. And if they're not available, this is the kind of hierarchy that we would use for decision making, spouse, adult children, and so on. And then include the rationale for how you came up with this, if they've already had a advance directive, or this is the patient's, we know that these are their preferences. So you include all this information right on the form. It is signed then by the patient or their surrogate, as well as the physician, PA or NP. And then on the back of this form, which we don't have on this slide, you would actually put the facilitator who did it, or the physician, NP, PO, or DO that filled it out. You would put it on the back who had the conversation. You also list on the back the healthcare providers, the DPOA, their name and phone number, so that if this is traveling from a place to place and you're not able to look that up quickly, it's listed right on the form. So that's really handy. Any parts of these that are not addressed, like for instance, some people really can't make a decision about artificial nutrition. I've seen this a few times. They're not able to make a decision yet, so they leave it blank. Anything that's blank assumes full treatment. So if they're not able to make the decision about it, and they were to have a stroke or something and they can't swallow, we would assume that they want full treatment. So that's something important to remember. And we already kind of talked about how you go about doing this. Pretty similar to the Honoring Your Wishes form. You really talk to your healthcare provider and let them know you're interested in having an iPost and actually interested in knowing if you are eligible for it. So like Heide said, this is designed for people who are within a year to the end of their life. Some 90-year-old people may not be within a year to the end of their life. Some, 30-year-old people may be within that range. So it's really need to know if you're eligible for it. And we really focus on the discussion. So the form itself is very helpful, but we sit down and still focus on the discussion. We try to gather everybody that we can, patients, their loved ones, their decision makers, family, close friends, and have a discussion really about the living well questions. What does it mean to you to live well? What is quality of life mean to you? What is important to you? It's really based on the patient's values, beliefs, and culture. And in this way, it makes the healthcare patient-centered, which is something we've been trying to do for some time now. And this really helps us to do that. And it also helps to kind of decide, how my healthcare status is at this point, and in 6 months, what do I expect that to look like? So you can have a nice discussion of the progression of your medical illnesses, because a lot of times people, have more than one illness, and how do they all interact together? So then it basically takes that discussion that you've had and makes that actionable medical order so that any person can use it. If there's like we said, nurses in the nursing home, nurses in assisted living, the EMS, if they're called, then they really know how to help you. If you send a person to the hospital for care, they really know what it is that you want. And again, it can be changed at any time, updated or changed. It really gives people peace of mind after having this discussion that then they'll get the care that they want. So where you keep the actual form itself then is, if you live at home, it's placed on the refrigerator. EMS is trained to look for it. And like we said, if you choose to notify the Joint Emergency Communications Center, they will recognize the phone number when you call 911 or a neighbor calls 911 or something. They'll know to look for it, so they'll look on the refrigerator for it. If you're in a care center, it goes in the front of your chart. So assisted living, nursing homes, it's in the front of your chart. In the hospitals, the information should be in the electronic medical records as well, easily accessible for everybody. So I'm just going to take a little bit of time and share some of my research that I did for my doctorate. I got involved with the Honoring Your Wishes initiative, almost a year ago, and started doing I became a facilitator and also an instructor as well. And I, for my project, got Institutional Review Board approval to implement a project. I chose one nursing home in Iowa City, and I had referrals from the social worker and the nursing home administrators, DONs, on patients who they thought would be appropriate. I completed 9 advanced care planning discussions, and all 9 of those patients decided to complete an iPost. Most of them had families available, children, some friends, so it was really nice. And then 7 people agreed to be in my study. And so what I did is, after the conclusion of the advanced care planning discussions, I gave a survey to the patients and their family members to try to assess how satisfied they were with the process of advanced care planning. And since this was a nursing home setting, they all, upon admission, you review their advanced directives. So it was the basic, do you have a preference for full code or, do not resuscitate? So that's, some people had a living will, some people did not have a living will. And so they really had not had extensive conversations with, amongst the family members. So this was really, including all of the family, and then giving them a survey. I also surveyed the healthcare providers at the conclusion of my project as well. But the really interesting part of my results was the patient and family satisfaction survey. And as you can see just by looking at the graph without even really reading it, is everybody's over on this side. Well, this is the very satisfied part. I know this is really small writing, but there was 4 questions that I asked, 4 very simple questions I asked at the end. Did they feel that the discussion was helpful? And on the left you see not at all, and on the right you see very much. So most of the people felt the discussion was helpful. The next question was, I feel better prepared to make decisions about my future health care. And again, most of the feedback was positive. The third one was, I feel discussion will improve communication among the healthcare team. And again, most of the people felt that. And that they felt that the facilitator did a good job in helping you with advanced care planning needs. Some of these questions were actually based off of national research. I did a full literature review, and this was some of the things that they had been looking at is, do I feel like this is improving communication, and do I feel like this is helping me make better decisions? So most people felt pretty satisfied. A couple people in the middle weren't sure how they felt. But the real positive part of this was the handwritten comments on the survey that people felt that, somebody felt this was a much needed process in regards to directives. Another person said they appreciated the opportunity to ask questions from a trained professional. And not all facilitators are nurse practitioners. A few of us in Iowa City are, but a lot of them are social workers, some are nurses, some are clergy. So some people may or may not feel comfortable asking questions. So, but they just felt really, the training really helped me. I had this conversation with patients before I became trained, and it was much easier to have the conversations after having trained so that you have a script of what you should say, and really to be able to open up the conversation to let the patients talk and not just having the healthcare provider do the talking. Another comment was this was an excellent addition, and they were very glad that it was available, and that the quality of listening and implicit support was remarkably beneficial, and the new system is amazingly helpful. So in general, in summary, very well received by the patients and families. The results of the healthcare provider survey basically kind of didn't really tell us anything new. Their results were basically that they didn't really know enough about it. They did feel that it helped with communication. They felt that it helped them know what to do if somebody was in the middle of a healthcare crisis. They knew who to call and if they wanted to go to the hospital or not go to the hospital. So it made some of that stuff clear. It also showed us that we still need more education. Everybody still needs to know a little bit more. They need to learn a little more, including nurses, social workers, communication between the nursing home and the emergency department and the hospital, and so that's what we're continuing to try to do. So then the take home is really, to ask your healthcare provider if you think an iPost would be appropriate for you, or maybe you have a family member or a loved one that you think that this would be appropriate for, is to just ask if that would be appropriate. It was just the last slide with acknowledgments for the Respecting Choices staff in La Crosse who really have kind of helped mentor this whole process. Linda Briggs is a nurse, and Dr. Bud Hammis is a physician who's come and helped start some of the trainings. And then Sheila Frost is in the Children's Hospital at the UIHC. So we have a little bit of time for questions if anybody has questions for Heide or I.
So the iPost is only available to those who are in poor health or very frail. So someone in my case, I'm single, I'm 64, I'm rather healthy, all that. I can't do one of those iPosts. So how does the medical community think of the advance directive with me when I have a stroke at the age of 65 and I can't communicate, but I do have an advance directive? How is that used then if it's not as valid as medical orders?
Yeah, it's definitely to guide the care, and you would be eligible for the Honoring Your Wishes, and then that would be involving your family and documenting what your wishes would be. So that would still take that information, and wherever you are at your inpatient care or rehab, and then if you didn't recover immediately, then you could probably do the iPost if you're able to communicate.
So would my person that's my caregiver complete the iPost? Is that what would happen?
The iPost can be completed by the family member. The iPost can be completed by the family member as a surrogate if the patient, him or herself, is not cognitively able to do it. It can also be overridden by them after it has been completed. But the point is that if you have a person with dementia who is in the end stage but still has some healthy heart, the family may still decide that this person should not receive a feeding tube and should not do a ventilation or whatever. So they can do that as surrogates. They can still fill it out if they can show they had the conversation before.
So in the advance directive, we would say we had a conversation about end of life, specifically about an iPost, and that would give them the authority to do that for you. Is that right?
Yes. When we talk about authority, it's really about empowering your healthcare advocate to stand up for you, because physicians want to do what the patient and the family want. They just need to be sure that that's what it is.
Okay. Well, I asked this question because there's such a large population, and a lot in Iowa City, of single people with no family members around. And so we've got friends as our advocates, but, I didn't know how that would play. Because I do have relatives, but they're far away.
And as we're implementing these Honoring Your Wishes advanced directives, we're finding that a lot of single people really don't have any family that they want to appoint. Right. And so some people really don't even have friends. And in that case, it's even more important that they fill out one for themselves, right? Right. So it's there as their voice. But then it's also important to talk it over with the healthcare provider so that the physician or nurse practitioner or whatever can advocate for them as well.
Thank you.
You're welcome.
So how do I, a healthy adult, fill out an Honoring Your Wishes advanced care planning?
We have several sites where there are trained facilitators in Iowa City or Johnson County. The first site that comes to mind is the center, the senior center. And there are several people available there. You can schedule an appointment with them. And we have very nice printed cards that tell you how to get in touch with them or just call the information desk. Then some of the faith communities are ready to provide that service. And I don't know that there is a registry for them, but you might ask if you belong to a faith community where you could find somebody. Some people are more comfortable doing this whole thing in the religious context. Where else do we do it, Maggie?
Mercy on Call.
Mercy on Call, of course. They have chaplains trained. At the university, you still need to be referred to the service somehow, but I'm sure that could be done through your physician.
And then also just add for the iPost, most of the nursing homes and several assisted livings in Iowa City have trained facilitators on staff. So we're still trying to catch a few more in the upcoming classes, but for the most part, all of the at least somebody in the nursing homes and advanced assisted living communities have available staff.
One other thing that I think is helpful is you had mentioned the website, and you can go on the website and see the documents, so you could see what the questions will be and what Honoring Your Wishes is really about. So honoringyourwishes.org.
And once you engage in a conversation with the facilitator, they will have resources. They will give you a little booklet with questions that stimulate your reflection and your thinking and guide your understanding. And there's more information available about medical options with advanced illness. If you don't know what the implications of tube feedings are, or being on a mechanical ventilator, or receiving CPR, we have to do a lot of education as to the benefits of CPR, because people think that, it's going to help them, particularly when really statistics show that somebody with their particular illness presentation may only have a chance of 7% of surviving to discharge. That means 93% of all people like them will not benefit from CPR. And then you need to know, what chances are they willing to take? Well, if there are no more questions, we want to thank everybody for the opportunity to speak on behalf of Honoring Your Choices. And we hope that you will find it beneficial and use it in your practice and your personal lives.
Thank you very much.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.